Good afternoon and welcome to Change for Global Health. This session is brought to you by the Health 10X Accelerator program. Today we'll be exploring innovation for global health, as well as the challenges and opportunities in this field, including as a result of the COVID-19 pandemic. Before we start, I'd like to acknowledge the traditional custodians of the lands we are on today. For me, that is the Gadigal people of the Eora Nation, and I'd like to pay respects to elders past, present and emerging. I'm Vesna Todorovsky, Program Manager for Entrepreneurship and Innovation at the George Institute for Global Health. My co-host today is Dina Tikova, Health 10X Program Manager at the University of New South Wales. This afternoon you'll be hearing from a wonderful panel. I'm a little biased, but they are wonderful. Dr. Parissa Glass, Director of Innovation and Enterprise at the George Institute for Global Health. Carolyn Hardy, CEO of the Catherine Hamlin Fistula Foundation. Dr. Jagnor, Senior Research Fellow and Head of the India Injury Division at the George Institute and Senior Lecturer, Faculty of Medicine, UNSW. Yakubu, Physician, Research Assistant and PhD Candidate in Global Health Systems at the George Institute. Greg Miner, CEO and co-founder of Evidently, and Dr. Pete Eyre, founder of CardioBionic. Thank you all for joining us today. To start, I'll pass to Parissa to tell us a little about the George Institute and why innovation is so important for global health. Thank you, Parissa.
Thank you, Vesna. Good afternoon, everyone, and thank you for this opportunity to tell you a little bit about the George Institute and some of our programs at the Institute. As Vesna said, my name is Parissa Glass, and I lead the Entrepreneurship Innovation Program at the George Institute. The George Institute is a non-for-profit medical research institute headquartered in Sydney, and we were established just over 20 years ago. In this 20 years, the organisation has grown from a handful of people in Sydney with a grand plan to essentially change the world. We are now about 750 people across the globe with major research centres in China, India and the UK, and collaborations and projects in almost 50 countries. And although there has been significant changes to the organisation in how and where we operate, our mission has remained the same, and that is to improve the lives of millions of people globally through conducting high-quality research, establishing partnerships across the globe, and all to in order to work to improve lives. And we do this by creating opportunities for sustainable and scalable solutions to some of the world's biggest health problems, which is non-communicable diseases and injuries, NCDs, or NCDs, I should say, are responsible for almost 70% of deaths worldwide, and significant majority of premature deaths happen in low middle income countries or emerging markets. And global injuries kill almost 5 million people annually. So the George Institute works to find better treatment to address those health problems. We know that over 5 billion people globally have no access to reliable health care. So we work to see how, as a collective, we can work together to strengthen healthcare and how we can make essential quality healthcare more affordable and accessible, with the ultimate goal of improving health and healthcare for everyone. We also understand that we ultimately need to live and operate in societies that are healthier and societies that encourage good health at population level. So we focus on policies and interventions that can have the biggest impact on health outcomes at population level. I'm sure you all know that in Australia and around the world there is significant amounts of money that's invested in medical research. But the impact of that investment can only be felt when the evidence and the innovation that's generated through research is given the platform to reach the people who need it most. And there are many ways that innovation can be translated, for example, through policy changes and practice changes. Another example is through commercialization, essentially creating sustainable solutions to address some of these big problems that we are talking about. At the George Institute, one of our focus areas for translation of our evidence is through creating what we call profit for purpose businesses. Businesses that essentially, as well as creating or generating income, they also grounded on impact and improving people's lives. And we've been doing this for a long time. And we have several businesses under our commercial arm, George Health Enterprises, that's working to scale the impact of our research. One example of those enterprises is LN Medical Devices, which is working to bring the world's first, I should say, affordable dialysis system to the markets. And to ensure we continue to work on our commercialization efforts and support our researchers to translate the research and evidence through commercialization, just over 2 years ago, we established the Genovate program, which is our entrepreneurship innovation program. And through this program, we work with our own researchers and we partner with innovators outside of the George Institute. An example of that is Health 10X, which Dina and Vesna will explain further. And going forward, we hope to create more partnerships in order to reach as many innovators as possible across Australia and to work together to solve those big health issues. So thank you again for this time to tell you about us. Please look at our website, reach out to us. We would love to hear from people who are keen to learn about global health. Thank you.
Marissa. Here's how today will work. We'll hear from our panel. They'll talk about their program of work, the unmet needs and challenges they face, as well as opportunities they see in global health, especially where innovation for global health comes into play. And we'll then hear from our two founders, Greg and Pete, who are Health 10X alumni. If you'd like to ask any questions throughout the session, please use the sidebar on your screen and we'll check for questions throughout. So let's start with our panel. Carolyn, can we start with you? Can you tell us a little about the Hamlin Fistula Foundation and the important work that you do?
Absolutely, I'm happy to. Thank you for including Hamlin in this. It's a really lovely opportunity to talk about what we do, what our hospitals in Ethiopia do, and some of the more recent challenges with COVID. I mean, it's just been such a year for everybody working in this sector, as all of you know very well. But for me, whilst COVID has shown us the carnage that can be caused by a virus we can't cure, it's just as tragic that out of the public spotlight, there are millions of people who continue to suffer from diseases and medical conditions that we can treat and cure. These diseases that have been long eradicated in rich countries such as polio, malaria, tuberculosis are continuing to wreak a terrible toll across poorer populations. And that's happening as well, despite COVID, it's continuing. So for Hamlin, when there is evidence that one of the world's poorest countries is on the cusp of eradicating a crippling medical condition that affects the lives of thousands of women, I think it demands our attention and our support, even through COVID. The Catherine Hamlin Fistula Foundation is the primary partner of Hamlin Fistula Ethiopia. We provide the bulk of the operating funds for this entity, and we support partnership development here in Australia, in the US and Canada, both from a programmatic perspective as well as from a research perspective. Right now, Hamlin Fistula Ethiopia is working to find and treat an estimated 31,000 Ethiopian women who are suffering with an obstetric fistula injury. Obstetric fistula is an injury caused by prolonged, unrelieved, obstructed labour, and it results in a hole between the bladder and or the rectum and the birth canal. The mother usually gives birth to a dead baby. Her grief is compounded by humiliating incontinence and the social isolation that comes with that. And these women will often suffer nerve damage and other injuries and infections as well. Over 2 million women around the world are estimated to be suffering with a fistular injury. It's prevalent in populations that live in remote rural areas where it's difficult to travel to health services, and communities which have very high rates of poverty and lack of access to health services. Think Ethiopia, Afghanistan, Nepal, countries that have difficult terrain to traverse, where it's difficult to get around anyway, coupled with very low access to public health. In most cases, a simple 2-hour operation can repair an obstetric fistula injury, and it costs around $700. Australian obstetrician and gynaecologist Dr. Catherine Hamlin lived in Ethiopia for 60 years, up until her death earlier this year. Catherine developed what's now recognised as the modern-day surgical technique to repair fistula injuries. And she went on to build a network of 6 hospitals across Ethiopia, which today employ 550 Ethiopian medical professionals. Over 60,000 women have had their fistula injuries, more than any other facility in the world, and thousands more women have had fistula injuries prevented, and surgeons from all over the world have trained at Hamlin. Our goal is to completely eradicate fistula from Ethiopia once and for all, and we plan to do this within the next decade. In February this year, we embarked on an 18-month patient identification program that sought to go district by district across Ethiopia to find every last woman with an untreated fistula injury. We trained 600 government health workers to assess and identify fistula. That started in the Amara region of Ethiopia, and in the first month alone, 40 new cases were identified. Some of those women had lived with this condition for a decade or more. All of those women were brought to the hospital. They've since received surgery to repair their injuries. We're aiming to be able to start declaring regions fistula-free by the middle of next year and reach full eradication in Ethiopia by 2030. Up until the COVID shutdowns earlier this year, we were on track to deliver on the rest of the campaigns across the country. Our challenge now is to mitigate the impact of COVID and to stay on track with this eradication target. While Ethiopia has so far contained the worst of the coronavirus, movement restrictions, transport barriers, fear of catching the virus itself are impeding access to essential maternal health services. Our new challenges now include all of the things you would expect. We have less patients presenting at our hospitals. We know there are new additional fistula injuries that have occurred because during the last 5 months, women have been unwilling or unable to travel to maternity care. Like a lot of other places in the world, we expect there will have been an increase in teenage pregnancies during this period. We've had the same challenges in obtaining and purchasing medical equipment and additional PPE that most health facilities around the world have had. Like everywhere else, we've had to introduce additional infection prevention controls and procedures at all of our hospitals, all 6 hospitals and all 80 clinics. And we've needed to look for innovative ways to support our midwives who are on the front line of both now fighting COVID-19 in these 80 rural communities in which they work, whilst also still trying to provide maternity and newborn health care services. In a lot of cases, they are now completely isolated. So we've had to explore and find and implement new ways to support them from both a technical perspective as well as a personal perspective. And that's actually been an opportunity for us because a lot of the platforms and new things we've introduced are just great and they will help regardless moving forward. Like everybody else, we've needed to rethink our FY 2021 planning and our budget. We know it won't be business as usual for quite a while. We also know that when a vaccine's found, it won't necessarily get to Ethiopia quickly or first. I think, given all of this, that we're right to be gravely concerned about the indirect devastation COVID-19 is going to wreak on mothers and health systems in our poorest nations. I think, as we all know, globally, our health systems are only as strong as the weakest links. So that's it in a nutshell from us, our challenges, our opportunities, what we're working on. We are optimistic eradication will be achieved, but there is a bump in the road right now. If you would like any more information about Hamlin, obstetric fistula, or this wonderful patient identification campaign. You can find that at hamlin.org.au, or you can email me directly. Thank you.
Thank you so much, Carolyn. It's such important work, and of course, a reminder that everything has been touched by COVID this year, and the ramifications of it will be ongoing for some time. But it's always fantastic to hear about the great work that you're doing in the field, and it shows the impact of, the impact that the foundation's work has is probably obvious to people because it's in the field, and sometimes we don't realize the impact that research work may have. So I'd like to switch now to Jagnor to tell us a little bit about her research program and the impact of that work, as well as challenges and opportunities there. Thanks, Jagnor.
Thanks, Vesna, and thanks, Caroline. What a beautiful goal to have, a fistula-free world. It kind of sets up nicely to something that I wanted to talk about, because it's one of the gender-related issues as well. And I would, as a researcher, I could probably talk for hours about my research work, which would span from all unintentional and intentional injuries to health systems and policy research. However, I'll try and stick to the issue of burns. Again, as I just mentioned, it's kind of a gendered issue. So I'm going to take you to India and the Indian subcontinent overall, and highlight some of the burdens and risk factors and the challenges we have with respect to burns treatment and rehabilitation. So there are around 11 million incidents of burns globally, out of which 7 million are in India alone. And if you were to look at male to female ratio, it's 3:1. And in terms of incidence, the incidence of burns is greater than tuberculosis and HIV combined. And in India, there are more burns-related deaths among women than maternal deaths. So it's a big issue. It's when you're looking at a graph or a globe of the disease burden, India is the red dot in there, which highlights that it's one of the biggest one over there. However, within the subcontinent, the risk factors could vary. So burns can be caused due to thermal burns, fire and scalp-related burns, chemical burns, radiation burns. They could be intentional, they could be unintentional. And one of the arguments perhaps could be that women, because of their cultural duties of cooking, are perhaps more exposed to fire-related burns, and that's the reason we see such a high incidence in India. However, we are unsure that is really the cause. One of the bigger projects of Gates Foundation has been towards working for clean and safe cook stoves, called the GAVI program, and that's been in place for a while with a great outreach. If we were to look at the intent of the burns, it kind of varies. In what we find in our neighboring country of Pakistan is that there are a lot of chemical burns, that is acid-related burns, which are often on the face of the victim, and that's intentional. In Sri Lanka, on the other hand, we find that a lot of women who are experiencing domestic violence use burns as a mean of suicide, and that's where we get the burden. Whereas in India, dowry has been one of the bigger reasons in the past, and there have been laws in place since mid-1980s, which has kind of seen a drop in incidence for a while, but it hasn't been ongoing. So that's kind of a bigger picture, and it's clearly societal. There's perhaps little that the health sector in itself standalone can do in terms of preventing burns, but there's a lot that can be done in terms of secondary and tertiary prevention. And to my mind, the biggest challenge is rehabilitation. So yes, there are issues with first mile and last mile connectivity, but our research in the past 5 years shows that there are a lot of opportunities available in facility treatment. However, when it comes to rehabilitation, because it's an ongoing, prolonged rehabilitation that's required, and it's usually women who are, as it is, not treated well and perhaps have been victim of violence to begin with, they do not have access to health services. Now, it can be quite broad spectrum and can be leapfrog to address the greater challenges of health system malaise overall, perhaps. And perhaps this is an entry point to look at how how we can attend to some of the physical access challenges for other issues, for example, even stroke. The second issue perhaps is the health literacy itself. So a lot of health professionals will tell you that we try and communicate to the patients that you need to comply and adhere to physiotherapy and you need to do X, Y, Z, otherwise you will develop contractures and this would lead to disability, etc., etc. But our patients never adhere to it. And it has been intriguing to me that often when you ask the patient, were you spoken to? Yes, I was. Did you understand what you were asked? Yes, you were. Okay, let's repeat. Let's understand what did you really understand. And it's this. They have no idea what a doctor refers to when they're talking about contractures. They do not understand what the repercussions would be. And one of the things that we found was being done in one of the NICE health facilities was showing them photographs of what is happening. And then thus there is a big communication gap. And I wonder if there is a room for innovation in bridging that communication gap and thus leading to better adherence and lesser disability. Stigma is a big issue. However, human resource training in itself is a big issue because it's not a very rewarding job. It does lead to a lot of disfigurement. Health professionals struggle in being motivated and in upkeep of what is available and how to work across multidisciplinary teams in rural parts of India where perhaps a tertiary multidisciplinary team would be 300 kilometers away. So it's not only a challenge for the patients, but it's also a challenge for the healthcare providers. And as was being mentioned, COVID does provide some great opportunities because it's kind of pushing everyone to move towards digital health and how can we improve services through digital health platforms. However, I see it as an equity issue. Women from rural, low-income background would not have access to digital platforms. B, they would probably not have enough resources in their hand or literacy levels to use them. And once again, it's perhaps about leapfrogging on what can and cannot be done in the context of burns in India. So that's a quick snapshot from me, and I look forward to hearing on everyone else's thoughts on this issue. Thanks.
Thank you so much, Jagnor. Again, another vast problem with many potential solutions and still so many unmet needs. Thank you for sharing an overview of your work. We'll speak to our other researcher here, Yakubu. We'd love to hear about your career experiences as a physician and your experiences now and thoughts around health challenges as a PhD candidate.
Thank you so much, Vesna, and thank you everyone for coming online and listening. Quite great work happening in Ethiopia and in India, which I can identify with. So I trained as a family doctor in Nigeria before coming over to Sydney to start my PhD. And I think equity is something that I have seen on the coalface of primary care. It's a difficult thing to deal with. And my work currently focuses on health workforce. So in essence, everything that Jagnor has talked about and the Hamley Ethiopian Fistula program has talked about will not be possible without health workers. Whether you want to talk about those who do the primary work of delivering healthcare services or those who manage and provide operational support. I am coming to terms with the fact that not only are healthcare workers important for healthcare delivery, but wherever you've had a high index of healthcare workers, it has been linked not just to universal health coverage, but also to development. That were countries where you've had a high health worker index, this attainment of sustainable development goals has also been possible. I can tell you about the World Health Organization 2006 report that has put the number of skilled health workers in places like Africa at 2.3 per thousand, or in Southeast Asia at 4.3. And when you compare that to what we have in the Americas or in Europe, we have numbers like 24.8. per thousand in the Americas, or 18.9 in Europe. So if those numbers are going to be delivering the basic health care that is needed for the various populations in these various areas, it's really an uphill task. So really, my current research is focusing on this issue of guaranteeing equitable access, irrespective of what part of the world you come from. But it's also about sustainability in access. Okay, and we talk about NCDs. There's a clear link between access to treatment and health workforce density. So really, that's not a point to argue. But going to what the challenge is, why does inequity exist? It's because really globalization as a force has come with a blessing, and it has brought its own costs. And with globalization, we've had migration trends increasing, and that has affected why a low middle income country will have this number of doctors and probably lose them, and the social issues that accompany that. um, COVID-19, of course, adds its own layer of challenges and opportunities. So if you have an area that has 2.3 health workers per thousand, imagine that some of those will have to divert their attention from a non-communicable disease to deal with COVID. And imagine that those ones who have survived from dying from the infection will have to deal with fatigue and psychosocial stress. It's not all a tale of woes. That there are opportunities that the COVID-19 has brought. I can tell you from an Australian perspective that we have seen the ability to use and leverage on what we have and increase their impact. For instance, public health specialists in New South Wales were helping with contact tracing in Victoria. That's really, redefining what health workforce index means, that we're able to, transfer skills without transferring physically people. The other thing really was a new sense of tax sharing, where you have like the police being involved in guaranteeing isolation and ensuring contact tracing as well. We probably would not have done that on a normal time. So it's making us think really about how different to use what we have and multiply the efforts of our current health workforce. Now, it's also making us think, really, how can we tackle the issue of equity differently? Because if with what we have, GP consults can be done via telehealth, and people in remote areas in Australia can have access to health professionals. It does mean that this is also possible in emerging contexts where health workforce index is really low. So this is something that it's an ongoing issue, trying to balance the force of globalization and what is driving the global health labor market, and say how can we ensure the issues of equity and the rights to health is guaranteed for such people that do not come to the global health markets with enough resources. Tough questions to answer, but there are opportunities. This is one area that social enterprise can yield some answers, to say, hey, how can we leverage on the collective global health workforce that is not attached to just one place and multiply their impacts without needing to shift them from one place to the other? What does this mean for migration? And I think that these are opportunities that we can explore. And I'm grateful to be able to share this with you, and I look forward to learning from every other person speaking here. Thank you.
Thank you so much, Yakubu. Really key insights there around how the density of healthcare workers within a country has a direct impact on the development and outcomes of that country. I think if we've learned anything from the COVID pandemic, that's certainly one of the things we've learned. And Carolyn mentioned that also, we're only as strong as our healthcare system. There are many, many gaps in healthcare systems worldwide. So you've heard now from researchers and from a non-profit that works directly in the field, and you see the impact there. We'll change pace now a little and hear from two founders who were part of our Health 10X program in 2019. So we're excited to have them here. They are Health 10X alumni. And we'll hear about their companies and also their experiences during this uncertain year. So, Greg, can we start with you?
Sure. Hi, I'm Greg. I'm the founder and CEO of Evidently. Evidently uses artificial intelligence to dramatically accelerate medical research by taking clinical data from any source and transforming that into a unified open data model that then allows researchers to do research very, very quickly. Most of the time and effort and money spent in medical research is around data at the moment, collecting data, streamlining it and organizing it and cleaning it up. So we solve that problem. We essentially link evidence-based medicine with value-based care, a population policy and health level, and in the hospital. So let's see, a bit about COVID. COVID has been interesting for us. We had a kind of agreements with 6 or 7 health systems in Australia to begin adopting and piloting our product. Those were supposed to begin in the February-March timeframe. Obviously, they all stopped because resources and budgets got redirected. Some of them are beginning to come back now. But we use that time to really think about and understand more broadly some of the bigger health system value chains. And because of at the same time, the world began to realize that this is the problem we solve is actually quite a pressing one. So a number of large global, some of the biggest software, one of the two or three biggest software companies on the planet, kind of reached out to us and we began to partner with them. And since then, we have begun focusing on international expansion. And the view that we get when speaking to customers in Asia, in North America, Europe, here in Australia, and to a degree the developing markets, we have some partners that are going to be servicing that, is once the COVID wave is done, once the vaccine is done, there's going to be a huge focus on immunization tracking and assessment and kind of broad population health coverage. And then if you think about where a lot of investment is going to be going, it's going to be really in this data and analytics space. COVID has articulated globally the inability of our health system to flex. Our health system is built on decades and decades and decades of medical evidence. We are unable to adapt quickly to shifts that can kind of change the foundations of that. Be it from a health workforce perspective, how many people do we need in the ED based on kind of flu symptoms in the population, to how much do we really need, to how many machines, how many ventilators do we need. We're just unable to flex. There's a broad recognition of that globally at this point. And so we are somewhat optimistic that on the back of that, we will begin to see, the foundation of that is getting your data right. And being sure you can start to look at prior evidence, challenge it, massage it, and begin running scenarios and AI and probability models, uniform data set to understand what happens if. So we're optimistic. We now have partners and pipeline here. We're having pipeline begin to close as we speak. Great, and yeah, we've raised a round of funding, and we have another one on the way. So that's essentially what's been happening to us through COVID.
Fantastic. Good luck with the raise at the moment. And Greg, if anyone is interested in contacting Evidently about potential collaborations or partnerships, can they do that?
Yeah, so our website is evidently.com with an I at the end, EVIDENTLI as opposed to a Y. You can reach us on that, or you can reach me at greg@evidently.com, and we'd be happy to see if we can assist.
Thanks so much, Greg. Pete, can you tell us about your company, CardioBionic, and the work that you're doing and perhaps challenges that you've faced this year because of COVID?
Sure. Hello, everyone. So we're developing a heart assist device to treat heart failure. So we're actually shifted our focus to develop a low-cost external heart assist device to now a fully implanted low-cost heart assist device that assists both sides of the heart, left and the right side. And if you look at end-stage heart failure at any one time every year, and there's around 10 million people dying of heart failure every year. So our focus is actually building a fully implanted total heart assist device, because left side heart assist device which exist in the world are mainly focused in the US markets, and those devices are about $100,000 each. And they get covered by insurance companies, but the rest of the world basically gets left out. And they only put in 16,000 of those devices for heart failure around the world, yet you've got 10 million people dying with end-stage heart failure who could have that device. So there's a big gap. So our mission is to deliver a heart assist device for about a quarter of the cost. And our main focus is we're working very closely with a leading cardiac surgeon in India, and also we plan to also go through Asia as well. So that's what we do. The year has been full of challenges. Personally, myself being a CEO and CTO, and also with the company, our focus has shifted from low-cost external devices to low-cost implanted devices. And one of the things that I've learned, it's probably not directly relevant to COVID, but is choose your founders very wisely. That's extremely important in developing a device. Make sure they're on the same page as you. The other thing that I've learned, and which we have done vigorously, is protect and patent your IP, your intellectual property. Make sure it's secure, which we have done. Then the third thing which I found was that Australia is a very hard place to raise a lot of money, particularly for a Class 3 medical device. And I originally started this project thinking we could kick it off with $1 million, but our latest thinking is we need $40 million. So I would encourage anyone out there who is developing a medical device to look overseas. And our latest capital raising has ventured into Singapore, and we've got two very, very large investors, each with very rich families with billions of dollars, who are completely interested in this device. And our latest strategy has shifted from going and trying to launch in the FDA in the States to now launching in the Singapore hub with TGA approval, and launching in as a lower cost device into India and the ASEAN markets through Singapore, which is a very high-tech hub. So our focus has changed a lot. One thing going through the Health 10X program has taught me, on Friday morning at 3 a.m. in the morning, I pitched to one of the largest venture capitalist companies in San Francisco and Singapore, and I think I did a pretty good pitch because I impressed one of the chairmen. So one of the things the Health 10X taught me as an engineer scientist is how to actually talk to the business world and present your ideas in a way that they understand. And the talk went very well. And in fact, the chairman of the company is having a meeting on the 26th of October, and we're very excited about the outcome. So, as I said, my expectations were a little low about the amount of capital I had to raise, and now it's a times 10 higher. So, COVID, I guess COVID. I worked a lot from home anyway before COVID started. So personally, it hasn't affected me very much at all. But I think it's affected the economic environment. I actually did I sort of deviated from what I was doing because someone called me and said, "Pete, can you help us build a ventilator?" And so I did that for a while and got involved in a project to build a low-cost ventilator, and then that sort of drifted off into nowhere, I think, then when we realized we didn't need a lot of ventilators. So it's been a really crazy year, COVID. I think it's affected the economic environment, and you think, well, people are still dying of heart failure even though they are still fighting this virus. And one of the other spin-offs we had was we had a ventilator, a portable ECMO company for respiratory disease that contact us, and we're in our third talk with them now because they want a low-cost pump to go with their portable ventilator, their portable ECMO machine. So it's been a crazy year. I'm still fighting on, and I'm waiting for hopefully a very positive outcome from a very, very large investor next week, and so are the other people who are working with me. So fingers crossed.
Thanks so much, Pete. And yes, if anyone out there would like to write Pete a $4 million check, we certainly welcome you to do that.
40 would be good.
40. Pete will take whatever size check is available. I've left links for all of the foundations and companies that you've heard about today in the chat, so please take some time to look at those and find contact details if you would like to contact any of our speakers. So you've heard today about the challenges and opportunities and impact of work from Africa to India and back to Australia. And you've heard a little bit about Health 10X. We're coming to the end of our session, so I'll pass to my co-host and co-program manager, Dina, and she'll tell you a little more about Health 10X, which is our Global Health Accelerator program. Thanks, Dina.
Thank you so much, Vesna, and thank you so much to all presenters tonight. And of course, I want to highlight Greg and Pete, who are our alumni, and we have very special feelings towards our alumni. So just very much briefly, what Health 10X is. For the second year in a row, UNSW and the George Institute for Global Health have partnered to deliver the Health 10X program, which aims to achieve social impact by accelerating the business growth of startups, developing solutions for global health challenges. And this year has been very successful for us. Despite all the odds, we have been able to scale the program nationally, and so almost the double of applicants and participants in our first part of the program, which is called Pre-Accelerator, with 5 absolutely amazing teams have been selected for 10-week accelerator program. We're now in week 10 of the accelerator part, and we would love to use this opportunity to invite all of you for Health 10X demo night to meet our finalists, 5 teams working tirelessly and passionately towards addressing global health challenges. The event itself will take place on November 4th. No surprise, it will be virtual, just another platform for you to learn. We'll leave the link for the event in the chat as well, but just a bit of a sneak peek. The event will be opened by President and Vice Chancellor of UNSW, Ian Jacobs, who will give his perspective as UNSW President on what we need to do to achieve more social impact. We'll hear from Stephen McMahon, who is Principal Director of the George Institute. I will and then from start issues from blindness to disinfection, and also helping people with various disorders to walk. So please tune in. I'll plug the link into the chat that we have here on the right. During the event, there will be a live part with the presentation, and there will be an opportunity for all of you to meet the teams in the virtual booth as well. Should be. And please reach out to us if you have any questions. We are on all social medias as well, and we would love to create new partnerships, collaborations, and just answer your questions. Thank you so much. Vesna, over to you.
Thanks so much, Dina. Thanks, Dina. You can find the link to register for demo night in the chat, and that will happen on Wednesday, 4th of November. So we hope you can tune in. That's all we have time for today. Thank you for watching. Thank you to our 6 inspiring panelists, Carissa, Carolyn, Jagno, Yakubu, Greg, and Pete, for their time and insights into their work. Maybe it's inspired you for an idea for your own health innovation. That's all we have time for now. Thank you. Good afternoon. And thank you so much to the SparkFest team for making this happen and for the opportunity. We hope you enjoy the rest of the festival program. Goodbye.